Welcome back to Smart Life. This is Dr. Georgiy Brusovanik, spine surgeon, and we're here with Dr. Jose Mena, Interventional Pain Specialist, to talk about sciatica. Dr. Mena, welcome back.
Thank you so much. Thank you for having me back here. Let's define sciatica, which is a very common condition. We see that a lot in office, as most likely as you do. And let's start defining what sciatica means. Sciatica is a misnomer. Typically, what the word it says basically is pain coming out from the sciatic nerve. In the reality, the pain is actually not coming from the sciatic nerve. It's actually coming out from the nerve roots in the lumbar spine that eventually they will branch and they will join into the sciatic nerve. The sciatic nerve is the main nerve that goes into the leg. So that's why most of the patients, they feel the pain in the distribution of the sciatic nerve. Typically, the symptoms, signs and symptoms of sciatica is that shooting pain going down the legs. The patient might have numbness, they might have tingling or paresthesias, and sometimes they might have some motor weakness. The real terminology is called radiculitis or radiculopathy. So normally it's a very common entity that we see in clinics. Most of the time it's being caused by two separate pain generators. One might be, the most common one might be the disc, which is the structure that we have in between the bones. And the second will be secondary to fixed lesions or arthritis or stenosis or narrowing. So which can compress the nerve and that can lead you to having the symptoms going down the legs. For the most part, the symptoms of sciatica or the condition of sciatica is self-limited. Most of the time, most of the patients, they're gonna do well. They normally the treatment initially might be conservative in the form of physical therapy. Sometimes we may add some medications to help them out with the symptoms. And for most of the time, most of the patients are going to do well. Now, if worse comes to worse and patients, they might not respond to the initial treatment, that's when we start getting MRIs or advanced imaging. And that's when we start thinking about injections or spinal injections into the spine to kind of relieve some of the symptoms. Now, A and B fails, last step of the treatment might be to start exploring, if it's deemed necessary, a surgical referral.
Besides sciatica in itself, what are the associated signs, things that a patient may feel in association with sciatica?
The patient having sciatica symptoms, normally most of the time they were going to have back pain, although that's not entirely true. Some of them will have buttock pain or pain going down the leg. They might have weakness in the legs. They might have numbness. They might have tingling. So basically that whole constellation of symptoms. Normally, the most important thing that we look on a physical examination is actually the patient does have motor weakness. That's actually what worries us the most.
You know, I see patients with sciatica often, and I see patients with motor weakness. I see patients for surgical consultation, and often, if I'm a second or third opinion, these patients will say that they've been told that they have to fix the problem. So, is sciatica dangerous?
Sciatica by itself, most of the time it's not. You're not gonna get paralytic or paraplegic after developing sciatica. Most of the time, most of the causes of acute sciatica tends to be a disc herniation. We know that the benign prevalence, about 76% of disc herniation, they tend to reabsorb. So already you get the compression away from the sciatica or from the nerve root in the spine. And those patients overall, over time, they're gonna do very well. Now, if we get someone in the office that they're having a foot drop or they have other symptoms like numbness in the gluteal areas, which are signs and symptoms of quad equina. Normally, those things they normally needs to be checked up on very quickly.
Dr. Mena, if a patient has sciatica and surgery, as we just discussed, is not always the option, so what are the things that someone can do to make themselves feel better?
So most of the time, we start them with a gradual exercise program through physical therapy. So the role there will be to learn the exercises, particularly for the back. So not only to treat the actual episode of sciatica, but mainly to learn an exercise program to prevent further episodes of sciatica. That's the number one and most important part of the management that we normally do. But sometimes we might need to add on some medications like anti-inflammatory medication, medication for nerve pain, to kind of soothe the symptoms. But overall, is just to try to get them through an exercise program. Worst comes to worst, patients are not responding to an exercise program. Normally, we go ahead, get an MRI, see what's going on. And based on that, we start thinking about epidural steroid injection, mainly from a transforaminal approach, to try to target a specific nerve that is being affected and try to get the symptoms better with the goal of, if it's typically caused by a disc herniation, most of the time those type of disc herniation tend to resolve. And the patient eventually, overall, they're going to do well. There's also other causes which are fixed lesions like arthritis, and normally you might have still the arthritic symptoms, but or the narrowing, but some patients might do better, they might do well, they might not require a surgical route. Now, I'll tell you that the patient that they fail A and B, meaning exercise program and or injections, those are the patients that we deem candidates for seeking a surgical consultation in order to fix the problem. When I'm referring a patient to you for surgical route, from a surgeon's perspective, what are the things that are you looking for, especially on a patient MRI or physical findings, that you would say, yes, this is the right candidate, this is the patient that will benefit from a surgical route?
I'm proud to say that in selecting patients, my armamentarium is good enough in this day and age where I can take care of almost any MRI. For me to operate on the patient and to make sure that it's the right candidate, I focus on 2 points. One is the patient has tried real conservative care. And with as much effort as patients look for a spine surgeon, they need to look for a proper interventional pain specialist like yourself, because the quality of the injections differs. An injection is not the same thing as an injection and is not the same thing as another injection. So I think that a trial of high quality epidurals is mandatory before embarking on an operation that's going to have some risk. The second thing is the patient has to say that they cannot live with this pain. And again, this has to come from the patient. It shouldn't be the doc saying, hey, we should take care of this because what if the pain doesn't stop? That's not a good rationale. It shouldn't be because I want to take care of this because I don't want to be too old when I actually end up having surgery. And it shouldn't be because of in case I get back pain. It should be a person saying, I've tried everything conservative and I can't live with this pain. And then the extent of a problem on the MRI will determine which operation. So a disc herniation, which can produce sciatica, deserves a discectomy. A degenerative disc in a younger person may mean a disc replacement. And then finally, deformity or significant degenerative disc often deserves a fusion. So sciatica is sciatica. A patient is suffering with pain going down the leg, or the cervical version of sciatica, which is neck pain that goes down to the extremities. If this patient failed conservative care and says that they cannot live with this pain, it's constant, it's destroying their lives, then it's very reasonable to consider a surgical intervention.
Actually, that's good. And let's actually define a little bit more about length of time, because sometimes some patients, they come in and they want to jump into surgery, and you want to hold your horses. Let's work with this. Let's try conservative A and B. What would be a good length of time that you would say to a patient, yeah, this is just enough time to consider a surgery? 3 months, it's 6 months, it's a year. What will be your definition of time?
That's a really great question and a really difficult question, Dr. Mena, because it really depends on the patient. A patient who is unable to control their bowel and bladder, has this constant numbness. It may be 24 hours and we are going for surgery, versus someone with on-off symptoms that have been there for years but who has not tried true conservative care. I would delay the operation to make sure that it's absolutely indicated. So I try not to base this on any kind of concrete dates. I try to base it more on what's really happening with the patient. Is there improvement or is there deterioration? And is this pain a sign of something dangerous?
And one of the questions that patient will ask will be as well, if I need a surgery, what's the risk of developing or having another surgery?
It largely depends on the operation. We have learned as a group, orthopedic spine surgeons, that reestablishing sagittal balance, meaning reestablishing the height of each segment, lowers the risk that other levels will deteriorate. We have learned that maintaining motion will not cause as much adjacent level disease as a fusion. But in the end, these are factors within a group of other factors that must be considered. So, with classic spine surgery, the chances of going back to the OR are as high as 36%. And that's from Dr. Nitin Bhatia, who actually published this data using University of Miami patient population. Versus now there are numerous papers from the US and outside that attest to the fact that newer operation, which you will see within the armamentarium of sort of the younger patient population, these operations are associated with a much lower risk of a problem above and below or a non-union, the kinds of problems that may lead to reoperation. It's important to interview your surgeon and ask him those hard questions specifically with the context of the operation that surgeon is offering you, because again, it depends on the type of surgery. Disc replacement, for example, much lower risk of adjacent level disease, whether it's cervical or lumbar, but it depends on the operation.
Actually, it's very nice always as talking to you about all this type of conditions. I hope the viewers, they find this very useful. Sciatica is a very, very common condition that we encounter every single day at clinics. And normally sciatica has its own treatment, and most of the time it tends to be favorable. And although I'm speaking here with a spine surgeon, not necessarily they need to be spine surgery related. I hope that everyone finds this useful, and we'll see you soon.